Good afternoon, everybody. I'm Christy Koenig, and I serve as the EMS Medical Director for the County of San Diego. Thank you so much for joining us today. We are pleased to welcome Dr. Jean Hern, longtime colleague and friend, who will speak to us on pre-hospital initiatives to combat the opioid crisis, national and California perspectives. I cannot think of anybody more qualified to speak on this topic than Dr. Hern. In fact, he will be honored this month for his work in this space with a statewide California EMS Director of the Year award, very prestigious. Dr. Hern is a graduate of UC Berkeley and UCSF Medical School. He currently works as EMS Medical Director for both public and private EMS agencies in California. As a researcher, he's published 53 peer-reviewed articles and 13 book chapters, including on the topic of creation of overdose receiving centers. His current research focuses on the EMS treatment of opioid use disorder and 911 paramedic-initiated buprenorphine. We are very thrilled to welcome him today to present the next talk in our monthly series of EBM lectures. Thank you so much, and over to you, Jean.
Wonderful. Thank you, Dr. Koenig. I really appreciate the opportunity to speak to your group. So yes, just a little bit of a background of who I am and my background in EMS. So I'm an emergency doc. I've been based at Highland for the last 27 years, and I'm also an EMS doc. This talk is really focused on what the 911 system can do to address the opioid crisis. There's lots of really interesting innovations that have happened around the country, some of which we have implemented in Contra Costa County, and some of which we're also rolling out to various places around the country, including San Diego in the coming months. So I work with the California Bridge program, and Vanessa Lara is our project manager. And so I have to do a quick shout out to her as well for all the help that she provides overall in the process. In terms of disclosures, yes, I'm the medical director for a couple different public health, public EMS agencies, Berkeley Fire and Oakland Fire in the East Bay of Northern California. I'm also medical director for a private EMS agency. I'm medical director for Global Medical Response in Contra Costa, which was the focus of our opioid interventions, and I have to thank them for their support in this novel process. I'm also the medical director for the EMS division within California Bridge. We've just renamed it EMS Bridge. So if you look www.emsbridge.org, it actually goes to the California Bridge EMS resources. And the hope is that we're going to have the opportunity to potentially expand to not only California. So we wanted to remove the California part and make it sort of nationwide potential. So let's start with a case and see if this resonates with anybody. It's 2 in the morning. 911 has just been initiated for a possible overdose. We find a 22-year-old who's unconscious, who is recently released from jail. He regains consciousness after naloxone administration, and he reports feelings of opioid withdrawal. And he is requesting to AMA. We've all seen this. This is the 2 a.m. call. It is something that is a regular occurrence. And the question is really, what resources can the paramedics in your county offer this person? And I want to sort of give, this is obviously sort of a discussion about interventions, but I have to sort of present what the standard has been for so many years. We provide supportive medication. We can treat them with fluids, Zofran for their discomfort, for their vomiting. We can offer transport to the emergency department, but the emergency department may or may not have a physician provider who is comfortable with any of the modern treatments for opiate use disorder. And this patient might self-discharge. There's this classic period after you give them naloxone where they're awake for the next, 1 to 2 hours, but depending on what they took, they might slip back into, being a little more sleepy, a little more altered. They may not stop breathing again. But then they're in your emergency department for the next few hours while they sleep it off or while it's being metabolized. And I think that's a really important thing to think about in terms of what processes we can start or we can consider to maybe change that dynamic and maybe even have a shorter emergency department length of stay, because it's really also important to remember that these patients are in the system, and they're a part of the system, and we are all facing overcrowding everywhere in every emergency department. So the gap in care really sort of goes between these two things. Like there's the assess and treat and maybe transport, but then there's potentially a new standard. And I'll talk about a number of possibilities here. You know, we can screen for substance disorder. We can talk about, you know, motivational interviewing. We can begin some of those discussions. We can provide an naloxone kit. We can transport them to a new place that we designate, and we can maybe give that data or their information to a public health substance use navigator who can then reach out. And we'll talk about those a little bit more. You know, we're in this really interesting time right now in that the last decade or so has been really fascinating from the American healthcare pharmaceutical opioid perspective. You know, there has been this massive and sustained exposure of the US population to opioids. It's remarkably a United States phenomenon in many ways. We're all subject to, you know, pain was the sixth vital sign. You know, we're not treating pain enough. All of the docs who work in long-term pain treatment had been marketed to by big pharma. You know, OxyContin is clearly like the best drug for treating cancer patients' pain, and it's an excellent drug. But the marketing was relentless and resulted in a lot of patients, you know, seeing these opioids. And then there was an awakening, right? And then we had this abrupt regulation and restriction of prescriptions, of physician prescribing practices. And so without a lot of infrastructure in place to treat these patients for their dependency or their addiction. And so what's been really fascinating is that, you know, organized crime has really filled this vacuum. The cartels have figured out that fentanyl is incredibly lucrative. It is straightforward to make. It doesn't require the opium poppy fields or the poppy fields that heroin traditionally needed. You need chemicals, you need chemists, you need a warehouse, electricity, and water, and you can pretty much synthesize fentanyl. And so that, and while as scary as that is, and now it's in pretty much all of the white powders coming up from Central and South America, it is fascinating that vacuum has really been filled by organized crime and the cartels. And now we're in this really interesting thing where these traditional models that we've had for treating patients with an opiate use disorder are really failing to slow down all of those overdoses, right? Like we would think that with all of our interventions, like overdoses should be declining, but in fact, they're getting worse. We have year-over-year increase in overdose deaths. And that's really been fascinating. It is, you know, fentanyl has clearly been a large portion of that, but we have this urgency now to implement sort of possible treatments wherever these patients are, however they want to get to it, and then link these patients to create an environment that improves survival. Now, you know, I don't want to be a Pollyanna to say that buprenorphine by EMS is the only thing that works or it's the best thing that works. It clearly, the data shows that as part of a larger system, buprenorphine has some remarkable benefits. But I think there's some other things that are also really integral into the process, and I'll talk a little bit more about them, most notably like data linkage, access to ongoing treatment systems, and that sort of thing. We know also that being in treatment reduces mortality. You know, if you get buprenorphine from a paramedic, they are safe from an overdose for the next 24 or 36 hours. So in some ways, it's like a long-acting Narcan. But being in treatment in the long term is what saves lives, and that is well proven. What's also interesting is that, you know, when we think of mortality differences, the difference in mortality for a patient who is in treatment, in long-term treatment, whether it's buprenorphine or methadone, there's some debate about which is the best one. It doesn't really matter to me, like as long as they're in treatment. That treatment reduces mortality by up to 70%. I would suggest that there are few things, maybe no things in medicine that give you a 70% mortality benefit. It is remarkable. So I want to just sort of paint that as the picture as we go through some of the things that we already know, and then some of the things that we sort of created and implemented in Contra Costa County. We also know that as we stopped prescribing opioids as providers, overdose deaths went up, which is sort of crazy. Like, you would think like, great, we're curbing prescriptions, you know, these patients won't have their dependence issues, we're going to, you know, decrease the overdoses and the deaths. And that is not the case. We clearly know that our opioid prescriptions have decreased, you know, over the last 10 years, but our overdose deaths continue to climb. I think we're over 120,000 per year now. And that is remarkable. And then it's also clear that it's not heroin, it's the synthetics. And it's mostly, and by that I mean mostly fentanyl. All opioid deaths are shown as the black line, but it's really the synthetics that have really made the difference. And what's fascinating is we see that that this process, you know, and fentanyl is truly in really everything. It's really fascinating because we review all of our overdose triggers, and I'll get to that also in a minute, in Contra Costa. And frequently we'll find somebody who is reversed with naloxone, and they're at a party, and they wake up, and there are, you know, 4 paramedics and a couple EMT firefighters around them, and they say, you just, you know, you had an opiate overdose, and we've just revived you with naloxone. And they said, there's no way I was doing cocaine. I couldn't have been doing fentanyl. I was doing, and they're like, actually, it's in everything now. And it's not uncommon to see someone who overdoses, but they actually don't think that they're doing fentanyl. So let's move on. We also know, and this now we're going to get into some of the data, and I'll present papers sort of throughout my talk. We also know that patients who overdose have a very high risk of death in the next year. So over 5% die within the first year. So 1 in 20 patients who survive an overdose will be dead in a year. Now remember, these aren't generally the 75-year-old patients with diabetes, asthma, vascular disease, has had 2 heart attacks and strokes. These are young people. You know, average age is between 20 and 40. So 1 in 20 people will be dead in the year. What's also fascinating is that a decent proportion of them die within the first month, and some actually die within the first 48 hours. There was a sort of a case series in the New York Times, maybe a year and a half ago, about a patient who got reversed, went to the ER, then was in withdrawal and AMA'd and went back home, and then overdosed again because he felt terrible at home, and then called 911. This happened 4 times in the space of 36 hours. So had literally had 4 different overdoses in 36 hours. And that is the cycle of withdrawal pain and symptoms, and the need to redose to treat those withdrawal symptoms. So we do know that the patients who overdose are at a high risk of death. We also know that if a patient is not transported, they also have a higher risk of overdose. So this was a study that had basically 1,600 patients in it that received naloxone, and about 40% refused transport. And if they didn't get transported, they had a 66% higher risk of overdose. And again, that is pretty well documented that these patients are at super high risk. Just to sort of, in very starkly say, California impact as an example, 110% increase over the last couple of years. This is, everybody knows that this is not going away, and this is huge. But the thing is that we are there. Like, the paramedics are at the scene of this disaster, right? And so instead of the old model of like, let's give them Narcan and try to convince them, even though that makes them feel terrible, let's, you know, see if we can convince them to go to the hospital, get some treatment. Maybe there's a counselor there, maybe there's not. We can at least do something. Maybe there's some other things we could possibly do. Also, in terms of their risk, San Francisco recently reported that they reviewed all of their PCRs and death reports in 2020. They had a really cool working relationship with their coroner, and 50% of the people who had a fatal overdose had had some sort of EMS contact in the year prior. So this is a perfect opportunity, and we have the chance to do it. So let me just back up a little bit and see sort of how this got started. So about 5 years ago, Highland, the county hospital in Alameda County in Oakland, had a visionary, a colleague of mine, his name Andrew Herring, and he really started to get interested in addiction medicine and treating patients with an opiate use disorder in the emergency department. And so they created this model called California Bridge. He's one of the PIs for the Bridge program. And the idea is that outpatient access is really hard. You have to oftentimes have insurance, have it together enough to go to an appointment. A lot of times outpatient treatment programs are pretty strict about, you have to pass drug screening tests to even get in the program, which is sort of silly because you're treating patients with an opiate use disorder, and yet they have to have a negative drug screen to get in the program. It's that part's really crazy. So Andrew was talking about, let's create a system so that you can have what we call a low friction access. If you show up to the emergency department and say, I have a problem with pills or opioids or whatever, you can get treatment and get hooked in with a navigator who can get you into a clinic appointment in the next 24 to 72 hours. So that was the sort of the model of the Bridge program. So Andrew and I started talking about, what about those patients that never make it to an emergency department? What about those patients who sign out AMA or for whatever reason can't, don't come in? So they sign out AMA, they're too sick for some other reason, or whatever. Perhaps we're losing out on those patients, or they go to a ER that isn't ready to offer those services, right? This is the crux of it. You go to we've recently changed the rules about X waivers, so docs don't have to go through this huge training program to get their X waiver. But up until a few years ago, there were plenty of emergency department providers who never used buprenorphine. Up until 5 years ago, I hadn't used it myself, and it's really fascinating that you could be an overdose patient and get transported to a hospital where none of the providers were comfortable prescribing buprenorphine, and I think that's a really interesting twist. So we sort of started to have this conversation, and we basically said, let's figure out a way to come up with a system. And so CDPH, sort of overheard some of our musings. We were just talking about this at one of the medical directors conferences, and they said, would you be interested in a pilot program? So we got together with the public health agency in Contra Costa and Bridge, and figured out that maybe there was a way for us to do this. So what we did was, our aims were to optimize treatment and to link interventions to emergency departments, and then talk about what the outcomes are. So let's just sort of step back for a second and think about the EMS encounter, which I think it's truly fascinating to talk about that and what else we can do as EMS providers. So I want you to just focus on the middle words in this slide, the overdose occurrence. This is basically what we think of when we think of as 911, right? It is a binary activity, the standard sort of you call, we will haul method. 911's activated, dispatch happens, the first responder ALS gets there, maybe a transport provider gets there, the patient gets transported. So that's the overdose occurrence. But each of the things on this slide actually have happened somewhere in the country. And so I started developing this model a few years ago, and we actually wrote it up, and it never got accepted. We were like, this is the spectrum of overdose responses, and no one would publish it. But it's sort of fascinating. So, and again, this happens all over the country, different places, Milwaukee or Florida or Ohio, and so all of the things above the overdose occurrence happen before a 911 happens, right? So you can screen patients who are at risk. You can create safe drug drops. You can do education. You can distribute first responder naloxone and Narcan. You can give out fentanyl test strips. You can help these patients, know what they're taking and reduce harm that way, sort of a harm reduction approach. Then the overdose happens. And then the lower part of the slide is all of the things that could happen after the overdose actually happens. Like maybe you take patients to a specialized hospital. Maybe you do a warm handoff to public health so the public health can reach out and talk to these patients and get them treatment. There are places around the country that have mobile integrated teams that show up at the patient's house the next day. They have 4 people. Coleraine Township is like the one that stands out in my mind. They've been doing this for like 4 or 5 years now. They have a rapid response team the next day. It's an EMT, a firefighter, someone from law, or a social worker. So EMT, social worker, someone from law enforcement, and a peer counselor who basically show up and say, we can get you into a treatment program today if you are interested. What else can we do for you? And that's a really fascinating way to do it. There's a place in Florida that the mobile team would go to the patient's house after an ED visit where they got buprenorphine and give them the buprenorphine for the next few days, like literally go every day until they got into clinic. And then the paramedic could also do the actual buprenorphine. So the things are in orange are the things that we did in Contra Costa. And I'll spend just a minute talking about each of them. And then I'll start talking about the data that we have and the outcomes. And I'll also sort of mirror that with the outcomes that we know from around the country. So the first intervention we did was we did this crazy thing. We just said, hey, why don't we have an overdose center? Like, we have a STEMI center, and we have a trauma center, and we have a stroke center, and more people are dying from overdose in that age group than any other thing right now. So maybe we should suggest that paramedics take patients to the hospital ED that has a substance use navigator on site, maybe not 24/7, maybe not even 7 days a week, but 5 days a week during like the swing shifts where, you know, a lot of the highest volume is, but they have access to the chart. They can reach out. All of the docs are comfortable with buprenorphine, have prescribed it, and have like are able to hook into the system. So we actually thought about this and we wrote it up and it got published. The idea was like, you know, maybe we should create overdose receiving centers. And so we designated the county hospital in Contra Costa as the overdose receiving center. So basically the clinical champion can start treatment immediately, the navigator can provide education and support and then linkage, and then the patient gets like better outcomes, lower readmissions hopefully, and gets evidence-based care. That's the whole point. So what does the data show thus far? So this is our first year, almost 2 years of data. And basically what we see is, these are all the patients. This is when we had 87 patients. I think we're up to 92 now. But basically the bright blue is the total patients. The sort of middling blue is the 7-day in treatment outcomes. And the light blue is if they're in treatment at 30 days. And it looks like if you go to the Bridge Hospital, you have a much higher percentage chance of being in treatment at 30 days. And that's sort of cool. The idea is you get a patient to a center that is ready to receive them, ready to give them treatment and get them hooked into a clinic system. They have a much higher chance of sticking with the program and sticking and therefore decreasing their mortality. I think that's actually pretty awesome. The next thing we did was we did the naloxone distribution program. We didn't think about this. It wasn't novel to us. We literally stole the program that had been modeled in a number of different places around the country. The closest one was Project Friend and Mary Mercer and Eric Silverman up at San Francisco General. And we basically took a lot of their protocols and used them. And the whole idea is that the state offers and still does naloxone distribution naloxone kits for distribution. And what was fascinating is that you can apply, if you are a community-based organization and you can show that you can do the training, you can distribute naloxone to the public, which is insane because the number of EMS agencies that does that is probably less than 10 right now. So you can be a librarian and give out naloxone to the public, but a trained medical professional, paramedic, can't do it in a lot of agencies. Does that make any sense to anybody on this? I mean, it boggled my mind. So we did it. We're like, hey, we asked for 1,000 doses of boxes of naloxone. We got it. We had a protocol. Anybody can walk up to any medic at any time and say, hey, do you have any naloxone? Here you go. What's your name? I don't want to give it. Fine. Here, have some naloxone. So it's perfect for at-risk patients, families, friends, or situations. So I think that's a really interesting thing. I know there's some chat things coming up, but I'm on a roll now. But maybe I should stop and see if there's any questions. Actually, I can't pull it up with my thing. So I'm going to keep going unless the moderator wants to cut in and ask me questions.
No questions in the chat. Keep going.
Okay, great. Let's move on. I hope I'm not boring anyone. So the third thing was the paramedic administered buprenorphine, and this is the sort of the sexy topic. Again, I think it's interesting, but I think it's actually the system in total that makes all the difference. What we did was we modeled our program off of the Camden, New Jersey, the Cooper Health program with some slight modifications. So our buprenorphine program is for opioid withdrawal treatment. So what's really interesting about our program and what's novel is that they're 911 medics. They're not community paramedics. These are street level medics that get the 911 call. In New Jersey, they can only give it by state law post naloxone. And we thought, you know, a lot of patients might just be in withdrawal and they would be good candidates. A lot of patients who come to Highland walk into urgent care, walk into our fast track area, and they're like, I'm in withdrawal. I have a problem, you know, with pills or whatever, with fentanyl. Can I get into clinic and get some buprenorphine? And we say, sure. So we thought that we were just going to expand that to the EMS system. We weren't sure how many people that would be. So it's post naloxone or abstinence. There's also potentially the bupe precipitated withdrawal, but that's an incredibly low number for us. We actually haven't had any cases of that in Contra Costa. But we have found that 2/3 of the patients that we've treated with buprenorphine are pure withdrawal, and 1/3 are post naloxone. So if Camden had increased their inclusion criteria to be pure withdrawal, they would have, you know, 3 times as many patients as they have. But the idea is no, it's a pretty simple algorithm. They have to reach out to an online medical control, and we provide that, and then they run through the case, and I'll go through the protocol. So this is the protocol off the California Bridge site. If you go to www.emsbridge.org, it should bring you up a page with a lot of our different resources, and this is one of them. And I'll go through the protocol. Basically what happens is that the paramedics assess for opioid withdrawal signs and symptoms. They look for any exclusion criteria. Now, when we designed this and we did the initial study and we proposed this to the state, we decided that we were going to, because it was a trial study, we were going to exclude patients under 18 and patients who are pregnant. It is clear that buprenorphine is the standard of care for pregnant patients now, and we will probably advocate modifying that criteria sometime in the next year, because clearly pregnant patients have needs for this treatment as well. And there are probably patients who are 16 or 17 who also have an opioid use disorder and would benefit. So that's certainly an interesting process, and we're going to start addressing that. But otherwise, the most important thing is to make sure the patient hasn't had any methadone recently. We say 10 days, or they're not in severe medical illness. They can't be in sepsis or respiratory distress, or be currently intoxicated, or not be able to sort of talk to the patient, talk to the paramedic and talk about benefits, et cetera. So the paramedics have a QR code. They do a COW score, which is the clinical opioid withdrawal scale. If it's 7 or greater and the patient is interested, then they call the protocol doc and they discuss the case with them. And it's a couple-minute call. The doc runs through the case, gives the criteria, sounds good, and they approve them for 16 milligrams sublingual. And then we'll often say, you know, if the symptoms are better, you can go ahead and give another 8. And they don't typically call the doc back, and they sort of use their paramedic judgment. And then at that point, we recommend transporting to a bridge hospital or an overdose receiving center. We sort of have conflated the terms I can answer questions about that in the future, but not a lot of LEMSs have been interested in sort of adopting the term overdose receiving center. So it's reasonable for us to say a bridge site since it has a lot of those same criteria. And then inform the patient that the navigator will reach out to them to offer additional treatment. Okay, whew. That was the third thing, and we'll get to our data in a second. But there's a fourth thing, which I think actually may be the secret sauce. And the secret sauce is the system integration. And I think this is the hardest thing, but I think this is the thing that makes all the difference. So basically, the idea is the paramedic provides care, the document on electric platform, First Watch then snoops the data and looks for triggers. And I would get overdose triggers. I get an email on my phone. There's a potential overdose trigger. Then our substance use navigator gets an email either from these triggers. They also get emails when there's a BUP case, because the doc oftentimes fills out a little Microsoft form, and then they can then log the contact and then they're alerted, and they can reach out for follow-up. And that's when they reach out to the patient and say, either they're in the ED and they say, can we get you an appointment? Can we get you a prescription? And it's, I think that might be the secret sauce that makes the difference in this system. And so the idea is that the Healthcare Services Agency in Contra Costa County oversees both public health, the regional medical center, and EMS. They're sort of all under one umbrella. So that allows them to share data. So our substance use navigator is a public health employee who is technically based at the county hospital. So that allows, we feel, a lot of data sharing without a lot of hoops. I think a lot of people have questions about that in general, but we feel like overdoses are a public health emergency. That allows for a sort of a lower HIPAA standard. And I also want to remind everyone that one of the P's in HIPAA stands for portability, which I think is a really fascinating thing. So we feel like that is a reasonable thing for our public health navigator to reach out for these patients and connect them to treatment. All right, so let's talk about the data and what we've seen so far. So this is the impact from our study. We of all the triggers we've had over 1,000 potential overdose triggers. These are patients that the First Watch just thinks might have been. We've gone through. This is when we were doing like our rigorous QA. We went through and identified basically 150 patients who were eligible. And then 87 of them had received buprenorphine by EMS in Contra Costa. In all of California now, we're up to about 106. San Francisco is live, and Alameda County is also starting their pilot program now. Now, this is important. These are the patients that got buprenorphine. But again, it's not as important as actually staying in treatment. And this is the thing that really sort of like struck us when we first started seeing this, is that it turns out that almost 40% of our patients were continued in care at 7 days, and almost a third, almost 30%, are continuing in treatment at 30 days. And we were a little shocked, because staying in treatment at 30 days is great for almost any condition, right? For diabetes care, for whatever. I mean, it's so hard for ER patients and EMS patients to stay in treatment and to get treatment. Remember, there's so many financial, psychological barriers, distance barriers to getting into treatment, and a lot of the sort of racial disparities that have been baked into our system are also at play. And I think that's a really important thing. So here we are at 30 days, having almost a third of our patients staying in treatment, and we think that's actually pretty remarkable. When we look at all those patients, it turns out that 77% reported a decrease in their withdrawal symptoms, and 22% noted no change, but we've had 0 cases of precipitated withdrawal in our population. We overall in the country, it seems like the rate of precipitated withdrawal, so those are patients who are on methadone, or in some cases, they've had a bunch of fentanyl in their system, and because it's fat soluble, there's always a potential. It turns out that rate of precipitated withdrawal is probably less than 1%, but it's about 1%. It's a real thing. Of all of our patients, we've had 8 patients admitted, but none have been related to their withdrawal symptoms as much as other things. Some were found to be in DKA, some were found to be suicidal, and that sort of thing. So those are the reasons, but none of them were actually admitted because of their buprenorphine, we believe. This is again the retention rates by destination. This is just a slightly different way of saying it. That if you have a 36% chance of staying in retention if you went to a bridge hospital versus 20% if you went to a different hospital or you left AMA. This is a really interesting slide as well. This actually discusses the racial disparities in Contra Costa, and there's perhaps the most interesting point about this is that African American data, the sort of second group of columns there, we found that the sort of royal blue color is the percent population. The middle column is the overdose death percentage. So of all the overdose deaths, 17% of overdose deaths in Contra Costa were African Americans, which is fascinating because it's twice the number of the population. So really sort of overrepresents the population in Contra Costa. But what was fascinating is that our BUP intervention patients, 21% of them were African American. So there's something about this data. This is our first year of data. Something about this intervention that engaged African American patients more, perhaps. We know that the overdose crisis and the opioid crisis has affected African Americans worse than other populations. So perhaps an EMS intervention has the chance to sort of address that disparity. Just a couple more things. Obviously, we know that the overdose deaths are really driven by fentanyl. There's lots of drama about the coming wave of opioid overdoses, and it's here. We know that it's only getting worse, and that the pandemic overdose deaths spiked, especially amongst people of color, and that fentanyl is a public health issue. So we know also that there's a high amount of cross-contamination, and about over half of our patients actually reported fentanyl use. But there's a lot of discussion about if patients are on fentanyl, then they can't get buprenorphine. The outpatient addiction docs are very hesitant about that. But it turns out that amongst our patients, over half reported specifically that they were using fentanyl, and we didn't have any adverse outcomes. Just a couple other papers I want to mention, and then I want to open it up for questions as we get towards the end. I just have about 10 more slides. So this is actually a study, this is a multi-center study in 6 US healthcare systems. Billy Soares is actually one of our residents at Highland. And the idea is to look at emergency department visits for non-fatal opioid overdoses. And it turns out that overall in patient volumes decreased during COVID, right? However, opioid overdoses got way worse. And it turns out that was often the African-American population as well. So the opioid overdoses were an important consequence of the pandemic. People felt more isolated, perhaps that was part of it, but increased in excess overdoses and deaths. A couple other things I wanted to say that Contra Costa in California, we are not alone in showing good outcomes. This is the Camden group, and Jerry Carroll is an EMS doc and an ED doc, and also an addiction board certified addiction doc at Camden. And they were the ones who pioneered this. Again, they can only give it in the post-naloxone setting, but they have had about 200 patients so far. They're paramedics. They don't actually give them a hard date for follow-up. They basically say, you can go to this clinic any day of the week and get in, because there are sort of spots saved for these patients. They've also shown remarkable decrease in their withdrawal symptoms. Their follow-up rates are in the 30 to 40% rate, but again, it's only post-Narcan. But 50% of their patients sign out AMA. Their study, this is just the editor's summary, that prompt administration of buprenorphine by a trained paramedic improves withdrawal symptoms and engagement in subsequent treatment. And so buprenorphine in patients with precipitated opioid withdrawal because of their naloxone is practical and valuable. So a couple final things. What we know as a given is that patients who are in established treatment programs with buprenorphine are at a lower risk of death. 70% reduction in mortality. Here are some things that we're not as clear about, right? So we don't know as well how these non-traditional models of care perform. So starting a patient, the standard was always the outpatient clinic addiction clinic or pain clinic side of things. We're not as clear about starting patients on buprenorphine in inpatient settings or in the ED, or maybe starting them in street clinics or needle exchange programs or EMS. We're still in the very early stages of this data, and NIDA is about to fund a long-term study for buprenorphine probably. I'm getting little rumors of it, so that may be a way for us to definitively know this. But at least from our data so far, and it's only a handful of systems, it seems like it's pretty safe and pretty effective. I want to do just a quick case review. This is a really interesting case for us. This is one of our cases, an actual case. This is a 26-year-old male who had a COW score of 19. One of our on-call docs, who isn't EMS certified, but they're addiction certified, it was one of their first calls, and they were sort of uncomfortable with a patient getting fentanyl or getting buprenorphine because they had had fentanyl before. So they authorized 2 milligrams of buprenorphine. The protocol says 16. And the paramedic was like, what the heck am I going to do with that? So literally got out their scissors and cut the 8 milligram strip into quarters and gave them like this tiny little dose of buprenorphine. Turns out it didn't help. So the patient continued agitation, continued withdrawal symptoms because it wasn't enough. And they got to the hospital and they sat on the wall and they weren't seen because it was overcrowded for 2 to 4 hours. And at the 4-hour mark, they left. So they didn't get treated, they didn't get seen. And our learning points were that, maybe that higher dose made the difference because our patients are already feeling better. So they're not agitated, they're not feeling terrible, and they're starting we're starting to treat their agony and their withdrawal pain. So that's an important thing. So these are the active programs right now. Alameda County is just starting. San Francisco Fire is active as of April 1st. And then we have confirmation, obviously, that San Diego is going to be starting soon. Hern and then the Tri-County area of Monterey, Santa Cruz, San Benito are going to go live in the next month. And then there's also some interest from Riverside and Lynn Empire, as well as SAC Metro and YOLO. And then I'm going to just finish with a couple testimonials. This is actually quotes from that our substance navigator got. So I was very sick in precipitated withdrawal. They were able to offer me Suboxone. I was able to take it right up there on the spot. That 30 minutes was vital in getting back to normal. Even though it was only 30 minutes, it helped me. We were able to go to the hospital where I received care and got more Suboxone. Made the biggest difference in how I felt, and was able to come to and realize what was going on. And that's the interesting thing, is that the addiction docs that I talk to, there's something about getting them stable enough times that they stay in treatment. And maybe it's seeing buprenorphine a few times, maybe not the first time that they're on it, they get hooked into treatment, but maybe seeing it enough times, they're like, oh, right, now I'm more stable. I'm not in withdrawal. I'm not intoxicated with a narcotic. I'm right in this middle zone where I can take care of my stuff. It ultimately led me to the road to recovery. I'm in recovery, and having that restarted my life. Because of the medication, I'm able to do things now my life would have been possible. I think it's great you guys are able to offer it. I've been able to function on an everyday basis. I'm now a student at UCLA. And that's pretty cool. Anyway, so that's just one of the ways it's helped me. I've been waking up every day, very grateful. So it all started with the medication. Just want this program to be able to offer to everybody. I know how helpful it was for me. I could see the difference. Could really make it. People chose to take it. So what's also interesting is that our paramedics are also thankful. When you talk about burnout, when you talk about resilience, the overdose patient is a difficult one because you may not have a lot of options to treat them. Our paramedics seem, there are a number of champions who are like, this project is really good to help people who are looking for treatment. It's made me feel more comfortable talking to patients about substance use. I feel prepared to share resources. We spend a lot of time talking about motivational interviewing in this setting. And I think that that's a really interesting thing. I'm glad leadership implemented this protocol. I'm glad we finally have something to offer patients. And I think that's really, really the key. We have all, addiction and use disorders have affected all of us, whether it's in our own families, our colleagues, you know, or you know, neighbors or friends, and it's something that like having that ability to offer something, I think has been very powerful for our paramedics. So paramedics report comfortability asking a patient about their opioid use, and it really increases their ability. The project is good to help people who are looking for treatment, make me feel more comfortable, and that's it. So final takeaways is that it seems like medication-assisted treatment in the field is effective, seems like it's pretty safe, and that the education reduces stigma. It's 12:45 now, and I want to offer people a chance to ask questions.
Thank you for the fantastic presentation. Very compelling data, very comprehensive. And we'll open it up now. If you have a question, either raise your hand or put the question in the chat. And while we're waiting to see if there's any questions, I'll go ahead and start. Do you want to comment about the use of Suboxone? We call this buprenorphine, but of course it's a combination, and why that was chosen for this particular setting?
Totally. So it is an interesting addition. So what was very strange, so buprenorphine as a mono product, is very helpful. It's taken in a pill form and doesn't get absorbed as quickly. The Suboxone is buprenorphine and naloxone combined, and that formulation was created because there was a concern that buprenorphine itself would be diverted and used in a different way, like melted down or injected or that sort of thing. And while that is entirely possible, the thought is that if the naloxone is like attached to it, then if it were melted down, then you would basically like, you couldn't get high off of the combined product because you'd have naloxone there already. It turns out that if it's taken in the sublingual form, the naloxone has a very high, what we call a first pass effect. And so often the liver will carve that out pretty quick and renders the naloxone not as effective. And so they get the buprenorphine. So we found that the sublingual strips is a much easier way to deliver it with a pretty rapid absorption. So that's why we've chosen that. It's possible to use the mono product, but we found that the Suboxone strips makes a lot of sense, and it makes people understand it. It's like the little breath mint strips, and so that's why we think that that's the better product.
Excellent, thank you. I'm still not seeing any questions, so I'll ask another one. Can you comment more on the 16 milligram dose? Do you think that might even go up higher at some point, or what went into that decision?
You know, it's a great question. It turns out that, you know, when we first started, again, the addiction docs have this really interesting scenario where they're seeing somebody in clinic who is using every single day. And they might have like fentanyl on board now, and they may not be in withdrawal. So the addiction docs in clinic oftentimes do what's called like a microdosing regimen. Well, they'll do this weird taper where they'll like start with like 1 milligram or 2 milligrams, and then they'll like they'll like do this cross fade or cross taper as the patient starts using less, and then they're using more buprenorphine and that sort of thing. The challenge with that is, and with the smaller doses, is that there's actually probably a greater chance of sending patients into withdrawal with a lower dose because you don't like hit all of the receptors. So we started using, we call it the SBD, the single big dose, at Highland maybe 4 years ago. And we've actually published a paper on it. Andrew has, about it's like 500 patients who got a large dose in the ED. And and that average dose, it was 12 milligrams plus. So anything over 12 milligrams, we considered a larger dose. And again, they had like a 1% withdrawal rate. And so the theory is that, you know, what's funny, when we think about giving medicine, we tend to say, oh, well, we're nervous about this. You know, I haven't given it before. I'll just give a little bit. Turns out giving just a little is actually maybe worse. So and because buprenorphine has this really cool ceiling at 50%, you know, that turns on the receptors basically halfway. So you don't fall asleep and get intoxicated, but you don't have the withdrawal symptoms. So giving a larger dose is actually probably the right thing to do. And now the addiction docs who focus on emergency, and there's a number of them around the country, are like, maybe our dose should be more. Maybe we should start at 24, 32. Because again, the faster you can hit all of these receptors, then the chances of withdrawal go down. And so maybe it's a larger dose to begin with. But 16 is what we've chosen. It's what they started with at Camden. But it's certainly reasonable that, and a lot of our patients, get the 16 and then they feel a little bit better, and the paramedics are like, yep, here, have 8 more, and move on from there.
Excellent. And keeping on the pharmacokinetics of the Suboxone, we want to avoid people leaving AMA because there can be a delayed onset. And so we're going to look at our educational materials as trying to get patients into the rigs before we treat them, for example, and try to discourage AMAs. But do you want to talk a little bit about some of the cases you've had and the pharmacokinetics for that delayed onset of precipitated withdrawal? Thank you.
Yeah, no, it's really interesting. So it seems like, most patients who get the 16 milligrams start to feel better in 10 to 15 minutes, but that continues to be, that drug continues to be absorbed. And so probably within it's an hour to 2 that it's sort of fully absorbed, and they're feeling much better. Now, we have heard of one case where a patient wasn't observed in a medical setting, that at hour and a half, they were found in the lobby of the ER because they weren't brought to a room immediately, and they were a little bit altered, and maybe they'd vomited, and so that was maybe one of the cases of precipitated withdrawal that I was talking about. And what's interesting is that again, even added to the cases, it's less than 1% of all the ones that we know about in the country, but it's also possible that and it's I think it's better to have these patients be transported. But interestingly, there are systems that are coming online right now where it's like a community paramedic that's sitting with a patient, and that the goal is to not transport these patients to the ER. But of all of the 91 cases we have in Contra Costa, only 1 is signed out AMA, which is actually pretty remarkable. And I think it goes to the fact that these patients sort of want treatment. Our medics are like, you need to go to the county hospital and get hooked in with the system and with care. And it's part of that sort of motivational interviewing, which I think makes a huge difference. So yeah, I think especially in this early stage, it's probably best to sort of encourage transport. I just feel like that gets us a better sense of how the patient's going to do, and a greater chance at follow-up.
Right, better data too, and perhaps in the future we can do more non-transport, like assess and refer, which leads right into Mary Murphy's question, asking, and this won't be so much for you, Jean, because it's specific to San Diego, so take a breath.
Okay, thanks.
The trial in San Diego, is there going to be an ongoing care plan for patients that are medicated in the field, primarily the available treatment center? And Tyler, I don't know if you got my heads up. I was going to ask you to weigh in on that, if you could, please.
Yeah, I could weigh in on that. So yes, the plan is currently, so EDs can be basically designated as a bridge site, as Dr. Hern was mentioning. And what that means is that they have a nurse navigator on site, a substance use navigator on site. So the primary way to connect patients with treatment is going to be through the ER, connecting them with a substance use navigator through the EDs. Luckily in California, all of our EDs are bridge sites, so that's the good news. We're in the process now of reaching out to all those navigators, making them aware of the program. We intend to kind of have some town halls with them just to make sure they have, all the information that they need about our program that's upcoming. The second route is patients who AMA from calls. So that's a little bit more tricky, but there is a whole web of resources within the county that offer MAT treatment for patients who are in need of it. So it's just a matter of connecting them. What our approach is probably going to be is to provide some general information that's left behind with the patient, but then helping departments to specify to programs that are within their region that are they're able to refer those patients to.
Thank you. Yes, it's a really, really important question. And I would say the non-transported patient warm handoff is a little bit on the cooler side right now, but we're definitely working on that because it's really important, obviously, to get people into treatment as well as just treating their symptoms. Any other questions or comments? I'm not seeing any hands or anything else in the chat. Jean, did you have anything to add on the follow-up piece of that?
No, I mean, I think that's, I think that is, I mean, I think that's the key. I think it's hard, but that's like I say, that's in my opinion, buprenorphine, don't get me wrong, buprenorphine is awesome. I mean, it clearly treats patients' pain, suffering, their withdrawal symptoms. They're not vomiting all over the ER, and they feel better. And our job, is to make patients feel better, right? That's why we went to medical school, and that's why we got all this training, is to like help our patients. And so buprenorphine in and of itself clearly helps patients' symptoms. It also prevents their potential overdose for the next 24 to 36 hours, because the buprenorphine, so in the post Narcan situation, when they get buprenorphine, it actually sort of displaces the naloxone, and it's because it's stronger. So it actually, it's stronger than all those other opiates. So it actually can prevent an overdose for the next 24, 36 hours. So that is inherently great as well. But I think the true key is that follow-up piece. Monterey and the Tri-County area, they're actually having a clinical champion who's an MD, ER and addiction person, who's actually going to be sort of like wrangling the resources to try to help figure that out. And I think it's that connection which I think makes the huge difference.
Makes it better and saves lives. That's so awesome. One last point I wanted to make is that we are working with Highland Hospital, where the experts are, as you can tell, to have an agreement to use them as an alternate base station just for the question of the pre-hospital buprenorphine, not for any other medical oversight type of direction. So Jean, I don't know if you have any comments on that, or what kind of, I want to share maybe what kind of training or how that works. You're talking directly to a doc, so it's a little bit different than calling poison control or calling our regular base stations within the county, for example.
Totally, yeah. So our base station system in Alameda County reaches a doc directly. It's either a resident or an attending, and they, our emergency department is very, like as you said, we are very focused on this kind of treatment because we have some champions. We have a number of emergency docs who actually went into addiction fellowships after residency. So and a lot of our residents actually do electives in the Bridge Clinic, which is super cool too. So it's basically, we're going to provide that sort of specialty knowledge and experience of using buprenorphine. Our residents are already taking the calls for patients in Alameda County. All the calls are recorded. It's just the narrow questions about buprenorphine. All the other protocols go to regular base station questions. But we're happy to help. We're actually going to be the resource for the Monterey, Santa Cruz area as well, and some others around the state. So we're happy to help with that.
Excellent. And Dr. Khan in the chat says the protocol requires several items that aren't yet well defined, as Mary stated, which would be great to clarify prior to the full rollout, including regulatory questions. Can EMS unit arrange non-EMS transport to an appropriate facility if they're not working with an approved TAD provider? This sounds great. I look forward to it being available to all the agencies. So yes, we're starting with a pilot program, and next year, if all goes well, we will look to expanding it. So thank you all very, very much for your participation. Thank you again, Dr. Hern, for sharing your time and energy and expertise with us. We look forward to working with you more. Have a great day, everybody.
Wonderful. Thank you so much. It was an honor. Thank you.